prepared it for a level of audience that I perceived you all would mostly be, and this is people in medical school or residency. And so in some cases it will be a broad level overview, and in another case I'll go through a little bit of detail. I recognize that there will be a quiz of some sort following this. I'll point out particular aspects in my talk that I'd like you to focus on so that you can answer those quiz questions properly. These are my disclosures. So we'll start with a discussion about initial evaluation and risk stratification. And again, I'm from the United States. Most of what I discuss today will be based on the United States guidelines, the American Urological Association guidelines. We've looked pretty carefully at how these relate to the European guidelines, and most of them are very similar. So I think the principles here are going to be consistent wherever you're practicing in the world. So some of the fundamentals here are that anytime you have somebody who comes to you in clinic with a neurologic issue and a concern for lower urinary tract dysfunction, there are always a few studies that are necessary. First of all, you get a history and a physical examination, you get a urinalysis, and if the patient voids on his or her own, you get a post-void residual volume. We can talk about how to measure that, but essentially you have the patient void, and then you want to assess how much fluid is left in the bladder. You can do it by an ultrasound or by catheterization. Below that, you'll see I have written some additional testing that can be performed on a case-by-case basis, and these would include a voiding diary, a pad test, uroflowmetry, and in only unique cases, cystoscopy. So here we have, based only on this initial evaluation, you can categorize a patient into a low-risk group or an unknown risk group. And what do we mean by risk groups? Well, basically, what we're trying to do here is stratify patients based on the risk of their kidneys for deterioration. So the principle here is that a high pressure bladder can cause kidney dysfunction and deterioration. So how do we identify the patient who's at very low risk for this, who requires less surveillance, versus how do you identify a patient at high risk for upper tract deterioration due to a poor bladder? And that's a lot of what we'll be discussing today. So low risk, for somebody to be categorized into the low risk group early on, based only on this initial evaluation, they have to meet a number of criteria. First of all, they either need to have their lesion in the suprapontine location or distal to the spinal cord. So in other words, if they have a spinal cord lesion in the suprasacral region, this would require additional evaluation. But if it's above that, suprapontine, or below that, distal to the cord, this could categorize them into low risk. They also need to meet some additional criteria. So they need to be voiding with low post-void residual volume. What does low mean? We'll talk about the different cutoffs for that, but there's no particular cutoff, but probably you use a similar one to what we do in the United States, which is about 300 cc's. Really varies based on the patient though. And you want to make sure they have no other related complications. And if their renal function has been assessed, that it's stable. And if their urodynamic study has been performed, that they're synergistically voiding. And if they have any upper tract imaging, it's normal or stable. And why do we stratify them? The main principle here is that we can surveil them accordingly. So in the low risk group of patients in the United States, at least, surveillance is typically not indicated. And you'll see this is a little bit variable. I think that parts of Europe probably would continue to perform surveillance in this group of patients, but suffice it to say that there will be watched less frequently than somebody at higher risk. Early on, the other group of patients would be categorized into unknown risk. So these are the patients with a suprasacral spinal cord lesion or with other neurologic lesions who don't meet all the other criteria I told you about. So maybe they have a genitourinary complication, or they have kidney dysfunction, or hydronephrosis on the ultrasound. Those patients, we wouldn't understand their risk yet, so they would need to be further evaluated. How do we evaluate them? We would perform upper tract imaging, renal function assessment, and urodynamics. So this is a big slide. This goes through a lot of what we think about early on. I wanted to give you a broad picture here. We'll delve into these different aspects in more detail in the subsequent slides. But this is what we're looking at. A patient comes to us. We want to get a good initial evaluation. Start with the history and physical. Look at the PVR, and review any other testing that's already been performed, then classify them, whether they're low risk or unknown risk, and then we go from there. So we'll start with the history. This is everything that it says in the AUA guidelines in terms of what we should be considering when we're asking about a patient's history. So there's a lot here, and as medical students and residents, probably most of it is typical things you'd ask about in a history, but there are other things that we'd like to pay close attention to because it's going to help us better understand their prognosis and their upper tract deterioration risk. So we want to characterize their neurologic condition that's resulting in their NLUT. Stands for neurogenic lower urinary tract dysfunction. I'm sure you've gone over that in prior lectures, but just for practicality's sake, neurogenic lower urinary tract dysfunction was formerly known as neurogenic bladder. So we've moved towards NLUTD or NLUT. This essentially encapsulates not only the bladder, but it provides the understanding that the urethra may be affected, the bladder neck, the surrounding organs. So we've changed the terminology, but if it helps you understand it, neurogenic bladder and NLUT can be thought of interchangeably at a very high level. So what do we think about? We think about the time of onset of their condition, the severity, the progression, the prognosis, the potential for recovery, whether they have a ventriculoperitoneal shunt. How do they manage their bladder? Do they void on their own? And if they void on their own, we should further ask, well, do you have to push to void? Do you have to bear down like you're having a bowel movement? Do you push with your hand? In other words, a Crede maneuver. And are they draining their bladder with assistance? In other words, are they doing in and out catheterization or clean intermittent catheterization, or do they have an indwelling catheter? What are their lower urinary tract symptoms like? Their LUTs, frequency, urgency, straining. All of this are things that need to be addressed and discussed. Do they have incontinence? What's their sexual function and desire, fertility function and desire, bowel function and bowel regimen are important because often neurogenic bowel and neurogenic bladder go hand in hand. Management of one may improve the other. Skin integrity. A lot of these patients with spinal cord injury may have pressure ulcers. These should be asked about and assessed on physical exam as well. An important area to focus on is autonomic dysreflexia. We'll go into that in some more detail soon, but particularly with patients with lesions at level T6 and higher, they're prone to this autonomic dysreflexia, which is actually a medical emergency and something that would need to be addressed quickly should they develop this in your presence in the clinic. Their renal function tests, complications they've had, what's their socioeconomic status, and how would that affect their clinical picture? And some of these are variable based on the part of the world that you're practicing in. But I think regardless, they're important to keep in mind. Does the patient have access or ability to ever come back and follow up, or will they be gone and not be able to see you back? That might change the management, for example. Other possibilities are listed here as well. Move on to the next slide here. So again, the history is important. It's important to understand the overall clinical picture, and it's important for the risk stratification. So this is there a suprapontine lesion? distal, or is there a lesion distal to the cord that would put them at low risk, or is it something that would put them at unknown risk? What are some examples of suprapontine lesions? Things like traumatic brain injury, in some cases, multiple sclerosis, if their lesion is only in that location, hydrocephalus, for example. Maybe the patient's had a stroke. In other words, a cerebrovascular accident. Those could all be suprapontine lesions, although these may have very serious effects on the neurologic side. Often they have a safer bladder. So often these patients will have detrusor overactivity, but in other words, their bladder would generally be safe in terms of pressures that could be transmitted to the kidney. Also, lesions distal to the spinal cord, patients who have had radical pelvic surgery or peripheral neuropathy, those are other possibilities for lesions in that location. And then the suprasacral spinal cord lesion. This can be a lesion due to spina bifida or spinal cord injury. Spina bifida, by the way, can be thought of as a spinal cord injury in utero, but often these can result in suprasacral spinal cord injury. There are many other potential etiologies. Tabes dorsalis. There can be different other lesions and possibilities that can result in that. Here's another way of looking at this. You heard from Dr. Paniker a couple of weeks ago. This is a paper from him and Dr. Feller, Dr. Kessler, very seminal paper in the field, and been cited probably almost 600 times. I've seen this image more frequently probably than any other image in neuro-urology, but it's a great image, and I'll walk you through it because it illustrates so many important points. So here's the suprapontine lesion shown in blue here. So what's the patient history like for somebody who has a suprapontine lesion and urologic issues? They have predominantly storage symptoms. So this is because this lesion leads to detrusor overactivity. So patient without a neurologic problem, this would look a lot like overactive bladder. So it's not an emptying issue, it's a storage issue. You can see in the schematic on the right, overactivity of the bladder, normoactive sphincter. This is the typical scenario for this lesion. Working our way down, this is the suprasacral spinal cord lesion. Hopefully you can see my cursor. I don't know if you can, but I'm looking between the blue and the green squares here. So in terms of history, these patients can have both storage and voiding symptoms. And on their ultrasound, often their PVR can be elevated. Post-void residual volume can be elevated. And on urodynamics, they're going to have that same detrusor overactivity, but they also may have detrusor sphincter dyssynergia. And they have this nice schematic on the right side there where you have the overactive bladder and the overactive sphincter. So together, when you have an overactive bladder squeezing when it shouldn't and the sphincter squeezing when that shouldn't, you can easily transmit the pressure up to the upper tract. And that is why these patients are at higher risk for upper tract deterioration and why they need to be followed more closely than patients who just have the overactive side of things in the bladder. Patients with the sacral or infrasacral lesion, in other words, it's below that suprasacral level, they have predominantly voiding symptoms. Their PVRs can be raised. On urodynamics, they may have a hypocontractile or an acontractile detrusor or bladder. And you can see the two scenarios in the schematic: underactive bladder with a normal active detrusor or underactive bladder with the underactive detrusor. So that's why these patients may have an increased post-void residual volume, and oftentimes that may also not be the case. On the right of this slide here, I show you sort of where the cutoff is for the suprasacral spinal cord lesion. This is about the level of the L1 vertebrae. So above L1, suprasacral spinal cord lesion. Below L1, you're no longer in that category. L1 can often go either way. So Physical exam, you assess their mental status, their ability for mobility, and importantly, upper extremity function. For example, are you going to be talking to them about performing intermittent catheterization? Well, if you do so, they need to be able to either do that themselves or have a caregiver who's willing and able to do that for them. Do an abdominal and a flank exam, pelvic and vaginal exam in females, genital exam and digital rectal exam in male patients. You assess the tone, the masses, the reflexes, and if the patient has a prostate, also the prostate assessment, do a skin integrity examination. At this point, you can also do a directed neurological assessment. You can assess their motor, sensory, spasticity, symptoms, etc., and signs. You can evaluate their reflexes, particularly the bulbocavernosus reflex. This will give you a sense, for example, if the patient was in spinal shock after a spinal cord injury, has this reflex now returned? And that's a good proxy for whether their overall condition has stabilized and whether their urodynamics assessment would indeed be a good assessment for what for the future months and years, or whether their condition is still rapidly evolving. You can also assess their tone of their anal sphincter and the voluntary contraction of their anal sphincter and pelvic floor muscles. Basically, assessing the reflex gives you a sense of whether their lesion is an upper motor neuron lesion or a lower motor neuron lesion. Probably you heard a little bit more about this from Dr. Paniker earlier in the course. But these are things we can keep in mind. Also, this targeted exam can give us a sense of where the lesion is and help us localize it. On the urology side, often the lesion has been localized already. Urinalysis, I'll just very basically cover this, but this is important to understand. For example, is there hematuria? Is there blood present in the urine? This would, of course, push us to look inside the bladder using cystoscopy. You want to interpret their findings in the context of their condition. And an abnormal dipstick urinalysis, for example, with blood present, may prompt a formal microscopic examination to make sure that the blood detected on that dipstick actually relates to the red blood cells on microscopy. Post-void residual volume, I've discussed a bit about it and what to do based on that result, but we haven't gone over much about how to measure it. So basically, the elevated PVR suggests that the patient has a bladder emptying abnormality. This can be due to either detrusor underactivity, in other words, an underactive bladder, or the bladder can work fine, but there can be bladder outlet obstruction or a downstream obstruction. And this could be related to a clinically relevant abnormality like UTIs or lower urinary tract symptoms, upper tract deteriorations. That's why it's important to get the PVR in these patients. And the elevated PVR should prompt additional workup per the appropriate risk stratification. What's the cutoff for PVR? Really, it's on a case-by-case basis. I think over time and seeing many patients, you get a better sense of this. But I think a nice common rule of thumb is that a PVR 300 and higher would often require addressment. To measure it, you can use either an ultrasound or catheterization. If you have an ultrasound available after the patient voids, you can assess the bladder volume and the volume of urine still present in the bladder. Alternatively, after the patient voids, you can perform in and out catheterization and measure the volume of urine that comes out upon catheterization. In patients who have an altered anatomy or habitus or ascites, these ultrasound measurements will, of course, be less reliable than catheterization. Here's what the risk stratification looks like. So you've already taken the patient who shows up in your clinic through the initial stratification, the low risk versus the unknown risk, for example, and you've reached the conclusion that that patient is at an unknown risk. Well, Now, what do you do next? There's a few things, a few different studies that are important to further risk stratify these patients. And they're listed in the table here. I'll walk you through it one after the other, but keep in mind that the patients get categorized into the highest stratum that they meet. So if a patient has any one of the high risk criteria, so if you look at the column on the right, if the patient has poor bladder compliance, but everything else is normal, they get categorized into that high risk group. Same goes for if they have new renal scarring, but everything else is normal, they're still high risk for upper tract deterioration. So you can see the low risk patients, and by the way, all of the studies are shown here. So you look at their renal function, you can measure that with creatinine. It's probably the most common way to measure it around the world. There are other assessments for GFR. These might include like a cystatin C measurement, for example. You can even measure GFR based on radio tracing, a radio tracer uptake and excretion, but these are much less commonly performed. So usually it's based on a serum creatinine. So you get your renal function, you get your PVR, presumably you have that already, and then you perform urinary tract imaging. I'm purposely vague here, but usually this is an ultrasound unless you need something else for another indication, for example, gross hematuria. But the point is, if you have axial imaging or you have more precise imaging, you don't also need an ultrasound if you have the information that you need from another study. Urodynamic, unless you want an ultrasound because you want a nice baseline measurement against which you can compare as you surveil the patient down the line. So that'd be on a case-by-case basis. Urodynamics is the other assessment. So renal function, PVR, urinary tract imaging, and urodynamics. So if a patient has normal renal function, low PVR, normal upper tract imaging, normal synergistic voiding on urodynamics, that patient's in the low risk group. If the patient has neurogenic retention or detrusor overactivity with incomplete emptying on urodynamics, that would put them in the moderate risk group. And then the high risk criteria are shown here. So on upper tract imaging, if they have hydronephrosis or new renal scarring, loss of parenchyma, staghorn, large stone burden, or on urodynamics, if they have poor compliance, vesicoureteral reflux, high storage pressures with detrusor overactivity or detrusor sphincter dyssynergy, that would put them in the high risk group. Again, why is it important to do this stratification? Because the surveillance of these patients differs. So low risk in the United States, we don't routinely perform surveillance for these patients. We reevaluate them if symptoms arise or change, and then we re-stratify them subsequently. Again, some of the specifics here will vary. I've been to some places in Europe where I think that the surveillance is a little bit more stringent than what's recommended on the in the AUA guidelines. So keep that in mind, that the practice patterns will vary to some extent, and maybe at the end we could hear from some of the experts on the European side in the room as well. On the moderate risk side, we typically recommend annual history and physical, annual renal assessment, upper tract imaging every 1 to 2 years, and repeat urodynamics as needed and or as indicated. And what are the indications? A change in signs and symptoms, new complications, upper tract deterioration. The high-risk patients, we monitor their history, physical, and symptoms annually, their renal function annually, their upper tract imaging annually, and urodynamics also repeating as needed. Some people, even in the United States, will perform urodynamics at set intervals in this high-risk group, but this comes from the AUA guidance here. Urodynamics, we assess for the risk factors of upper tract deterioration. Here are some of them: poor compliance, detrusor overactivity, and detrusor sphincteric dyssynergia. We'll go through these one by one. What's compliance? Well, I already mentioned poor compliance is a proxy or a risk factor for upper tract deterioration. How do you measure compliance? Compliance is the change in volume on urodynamics over the change in detrusor pressure. So you pick two different points on a urodynamics tracing. I'll show you how to do that on an example. And you look at the change in the volume and you divide that by the change in the pressure over that volume. So compliance is defined by the ICS as a relationship between change in bladder volume and the change in detrusor pressure. It's calculated by dividing the volume change, delta V, by the change in detrusor pressure, delta P det, during the change in bladder volume. And there's the calculation shown again. It's expressed as milliliters per centimeter of water. What's the cutoff for poor compliance? That's something that is not agreed upon completely, but you'll see that the numbers in the literature don't vary that much. I think most people would say somewhere between 10 and 15 is the cutoff. Below that, typically you're thinking the patient would be at a higher risk. Above that is somewhat reassuring. But again, there's no one cutoff. It really is a spectrum. You also should consider whether compliance changes over time from one study to the next. Here's a schematic. So this is drawn. This is not a real tracing, but I think when you're learning and familiarizing yourself with multi-channel cystometrogram tracings, this is very useful. So I'll just introduce you to it briefly. Probably you've seen these before, but on the left side of the screen is more or less a normal urodynamic study. You can see the first row is the vesicle pressure. This comes directly from a catheter inside the bladder. And keep in mind, as you go from left to right, we're filling the bladder. So you can see slowly the bladder's being filled, and we ask the patient to cough and to tell the patient and to tell us whether the patient has a sensation or a desire to void, whether they have a strong desire to void. So the whole goal of these studies is to mimic their normal bladder physiology. So you have a filling phase, and then you have a voiding phase. You can see there's a hashed line towards the right of that normal tracing that says permission to void. Everything to the right of that is the voiding phase. Everything to the left is the filling phase. So as we fill, we're monitoring the PVES, that's the catheter in the bladder. We're monitoring the P abdomen. This is a catheter in the rectum usually. That's in red here. So we look at the PVES and we look at the P abdomen and we take the difference between the two. And that gives us the P det. This is the detrusor pressure, the pressure that's actually seen by the wall of the bladder. This, for all intents and purposes, is the important pressure to be looking at for compliance and for other interpretation of the urodynamic study. Again, it's a calculated value. It's the difference between PVES and P abdomen. So you can see PVES and P abdomen are both non-zero numbers, but when you add them, essentially one is negative. Basically, you get close to zero. And that's the P det. So that's a normal compliance study. You can see, hopefully you can appreciate that there's a difference in the pattern between the tracing on the left of the screen and the tracing on the right of the screen. And on the right of the screen, you can see that P det is coming off of the baseline. Excuse me. So P det on the right of the screen, it starts low. It starts at the same value as it does on the panel on the left, but then it progresses. It increases as the bladder fills. So you can see that green line, by the time permission to void happens, it comes off of the baseline. And this is a typical scenario of poor compliance. Well, how do you know it's poor compliance? Well, you have to measure it and do that calculation. So what you do is you take two different points on that P det line. I didn't give you exactly the volume the bladder is filled with. I'll give you a case example shortly. But basically, you take the difference in volume and then you divide that by the difference in pressure and you get your compliance. You can make that calculation. So again, just pure pattern recognition here. The tracing on the left, normal compliance. The tracing on the right, low compliance or poor compliance. Here's a real multi-channel cystometrogram that demonstrates poor compliance. You can see sort of at the peak of the green tracing, that's where the permission to void is granted. And I hope you can appreciate that P-det, which is shown in green, I can see it well on my screen. Hopefully you can zoom in if you need to on yours. That P-det increases off the baseline, and it does so in a consistent way. What I can do, I'm just sort of eyeballing it. I see a p-det of 47 versus 0. So that's a change in p-det of 47 over a change in filling volume of about 200. So we'll do that calculation. 200 divided by 47, and this patient's compliance is between 4 and 5 milliliters per centimeter of water. So again, it's the change in volume, and the filling volume on this multi-channel cystometrogram is shown at the bottom. This volume goes up to about 200 over a change in detrusor pressure, which goes from about 0 to 47. And there are different nuances here, different important considerations as well, but that's essentially what we are measuring here. So detrusor overactivity is another consideration for risk stratifications. The occurrence of detrusor contractions during filling cystometry. These contractions, which may be spontaneous or provoked, produce a wave form on the cystometrogram of variable duration and amplitude. The contractions may be phasic or terminal. They may be suppressed by the patient or uncontrollable. Symptoms, for example, urgency and/or urgency incontinence or perception of the contraction, may or may not occur. I'd like for you to pay attention to this particular slide because you'll see it again, something similar on the quiz. So again, here's a normal tracing on the left, panel on the left here. You can see that there's a cough. This is typically a control. Patient coughs, the PVES goes up and the P abdomen goes up, but they go up at the same amplitude. So when you add these or basically assume one is negative and you add them together, then you get the difference, and p-det is essentially 0. Just another important point to keep in mind. You might see these spikes and wonder what they are. Well, usually they're just quality controls or a test for stress incontinence. Okay, can you cough for us? And we'll assess for any leakage. So this is typically what we would see here. So that's a normal tracing on the left, just with that addition of the cough. And on the right is a tracing that demonstrates detrusor overactivity. So what's the difference between the left and the right? Again, it's that green row, the p-det. And what you can see in the p-det here is that right between those two first hashed marks, we see a bit of a raised area of the green curves. This is a detrusor overactivity event. And if you look back at how that was calculated, well, it comes from the p-ves, not the p-abdomen. I'd want to make sure that this doesn't just come from a catheter issue in p-abdomen, for example. I want to make sure that it's a true detrusor overactivity event, and that's exactly what we're seeing here. So in terms of the pattern recognition, you can hopefully appreciate that on the left is normal, on the right is a detrusor overactivity event, and that green curve, that bump that you see on the right, that's not present on the left. Here's a real tracing of a multi-channel cystometrogram that demonstrates detrusor overactivity. You can see the third row is p-det. You can see that starting at a filling of about 100 cc's, again, that's that bottom row. I can see a volume of about 100 there. We start to see some detrusor overactivity in the green curve, the p-det. Okay, I just want to make sure that it doesn't have to do with the abdominal pressure. It's true detrusor overactivity because it stems from the p-ves, and you can see that these increase as well. Someone might classify this perhaps as phasic detrusor overactivity, which is something that can be seen in patients with neurogenic lower urinary tract dysfunction, neurogenic bladder. So just wanted to introduce these to you so you can appreciate these different features and that they're adverse prognosticators for upper tract deterioration. The third one I wanted to discuss is this detrusor sphincter dyssynergia. Essentially, the bladder and the sphincter are not working in a coordinated way. Normally, when somebody voids, the sphincter relaxes. In DSD, the sphincter doesn't relax, and actually you may see increased tone of the sphincter in the context of voiding. This is DSD. Discoordination between detrusor and smooth or striated sphincter function during voiding due to a neurological abnormality. That is, detrusor contraction synchronous with contraction of the urethral and or periurethral striated muscle. This is a feature of neurological voiding disorders. Here's another schematic. This demonstrates the normal scenario. Synergistic void, this is on the left of the screen here. You can see the EMG during filling is fairly noisy. This is a schematic of a patch EMG. You can see that this is a noisy pattern during the filling, and then it quiets during voiding. This is normal. So normally that sphincter has tone to it to ensure proper bladder filling. You don't want a atonic sphincter in the context of a filling bladder, or else incontinence would ensue. So you have a normal sphincteric tone in the context of filling, and then when the patient empties his or her bladder, that sphincter quiets, and that EMG electromyography quiets in the context of the void. That's normal on screen left. On screen right, we see detrusor sphincter dyssynergia. So instead of quieting appropriately in the context of the voiding, there is a increase in amplitude of the EMG. This is sort of the classic appearance of DSD. Here's a example of what it might look like in a true systemetrogram tracing. You can see that permission to void is granted towards screen right about 3/4 of the way through the study, and then you can see that there's increased EMG activity at the start of the void or the attempt to void here in the context of increased PDET as well. What's vesicoureteral reflux? I commented on that earlier. Here's an example. You can also ascertain this from a urodynamic study if you have fluoroscopy available. So you can fill the bladder with a little bit of contrast mixed with the saline solution, and you can take some spots of fluoroscopy. You can see in this particular patient's case, the bladder is smaller than the upper tract. This is not a healthy bladder. This is something where there's bilateral vesicoureteral reflux on both sides. So this might be an image you'll see again, but you can see this is patient's left. On your right side of the screen, you can see that the contrast dye goes up from the bladder up to the upper tract. And you're actually seeing the same on the right. It's a little bit less remarkable, but I hope you can appreciate that this contrast has started to go out the ureter on the patient's right, our screen left, and is making its way to the upper tracts as well. Here's our risk stratification again. Here's our surveillance again. The difference again between moderate and high risk surveillance, at least in the AUA criteria, is the upper tract imaging surveillance every 1 to 2 years in the moderate versus annually in the high risk. Just a comment about autonomic dysreflexia here. It's a condition that affects individuals with spinal cord injuries above the level of T6, or I should say at the level of T6 and above. This can occur when the autonomic nervous system, which controls involuntary functions like heart rate and blood pressure, becomes overactive due to a stimulus below the level of the injury. And the stimulus can be a full bladder, constipation, tight clothing, or other stimuli. It can lead to sudden and severe increase in blood pressure, potentially causing serious complications like stroke or seizures. And I mention this because it's an emergency, and it's an emergency that everybody who does urodynamics has to be equipped to deal with. So if you're performing urodynamics, or your office is performing urodynamics in patients with spinal cord injury or neurogenic lower urinary tract dysfunction, you have to be ready to deal with this emergency. So you have to hemodynamically monitor these patients, particularly with lesions at T6 or above. You monitor them during the urodynamic study, and if they develop autonomic dysreflexia, by the way, which is at least partially defined by an increase in systolic blood pressure, often 20 millimeters of mercury from the baseline. If they develop that, the next steps are as follows. This is very important. You have to terminate the study, so stop bladder filling immediately. Immediately drain the bladder, continue the hemodynamic monitoring, and be prepared to administer medical therapy for the autonomic dysreflexia. And this is often nitro paste or some nitro component to manage that blood pressure and this event. So you stop the study. You remove the stimuli by draining the bladder, making sure there's no other adverse stimuli, and you continue the monitoring and prepare to escalate care. Here's a couple of questions here. I think that they'll wind up illustrating the points and also prepare you for the quiz later. A 55-year-old male with spina bifida voids spontaneously. His post-void residual volume is 90. His urinalysis is normal. His upper tract deterioration risk is what? I don't know if we have the capacity for anybody to answer. If you put it in the chat, I'm not even sure if I can see the chat, but feel free to chime in if somebody knows the answer here. Otherwise, in about 10 seconds, I can move along.
Is it low risk?
That's an excellent suspicion. I think that you're certainly onto something, but in this particular
I think it is
case,
moderate risk. So
yeah, in this particular case, I think we need a little bit more information because, we don't really understand the potential. He's got spina bifida. So this is a suprasacral lesion. So even though everything else is very reassuring, because his injury is the suprasacral spinal cord, and we don't have imaging of his upper tracts, and we don't have urodynamics to understand his bladder physiology, really, he's still unknown risk. But your points are well taken. Let's get some additional information and go from there. So this same gentleman, he undergoes additional testing. His creatinine is 0.8. His renal, normal, in other words. His renal bladder ultrasound shows no hydronephrosis and normal kidneys. And urodynamics testing demonstrates synergistic voiding with normal compliance and no detrusor overactivity. Now his upper tract deterioration risk is what?
low risk.
Is it low risk?
Yes, exactly.
Low risk.
Exactly, low risk. So now we have the information we need to be able to support this low risk stratification. And based on the AUA guidelines, what would the appropriate surveillance be? Well, really, we wouldn't continue surveillance for this particular case in terms of urodynamics testing and ultrasound. We'd give him a careful discussion about symptoms and when his bladder physiology might change and how that would warrant additional evaluation, but we wouldn't routinely provide surveillance for that patient at low risk. There are some open research questions in the field. Hopefully some of you are interested in it. I think it's a very exciting field to be a part of. These are just based on, what I've sort of discussed with you today. There are multiple open questions that we don't yet know the answers to, some of which are, how can we accurately predict upper tract deterioration? And I mean this in a much more precise way than I've shared with you today. You probably suspect that not all patients in the moderate risk group are the same, and you'd be correct. Different patients have different disease courses. What's the difference between somebody in the early course of relapsing and remitting MS versus somebody with progressive MS in the end of the course? And how do these patients differ? And how can we accurately predict whether there's going to be any upper tract deterioration in a patient and to what extent their upper tracts will deteriorate over time? What do we have to do to prevent that? Now you're going to hear about treatment in a subsequent talk. So I won't go into the treatment today, but this is an exciting area to discuss in the future lectures as part of this series. How do you stratify by the etiology of the condition? So what about the level of spinal cord injury, for example? Is that important? These are things that haven't been evaluated very comprehensively yet. What's the optimal timing and frequency of urodynamics? We have some very interesting work coming out of our colleagues group, particularly the president of INUS, Professor Kessler. He's showing that early urodynamic studies are actually very telling in terms of the progression of neurogenic lower urinary tract dysfunction, and how can we incorporate that soon after spinal cord injury, and how can it help us better manage our patients? What do we do when urodynamics is not available? Maybe some of you on the line don't have urodynamics available in your center or in your country or your region for that matter. What's the best assessment to perform when we don't have a urodynamics study? And there are some bedside cystometry tests that can be performed. How do we do that? How do we standardize it? How do we get the best and the most information out of the study using only the resources that we have available? These are active areas of interest, including for INUS. So we have a whole group dedicated to thinking about this and better understanding how we can provide the best care for patients in the context of resource limited settings. Professor Kirshner Hermans is also involved in this as well. And then what about biomarkers for neurogenic lower urinary tract dysfunction? This is something that we don't have available yet, and something that is being actively worked on by many different laboratory groups around the world. So exciting opportunities for the future. I appreciate everybody's time today, and I think we've got some time left for discussion. If anybody has any comments or questions, happy to discuss them.
Yeah, Professor, we have a time. And thank you so much for this much informative lecture. It was very nice lecture. So
thank you.
So we are taking the questions. Raise your hands who has the questions. So I can see one question in the chat by Jargon Tainer. So his question was, what are the prognosis rate, for example, cerebral stroke, suprapontine or spinal MS plaque, infrapontine and bladder function?
Let me see if I can read that. Oh, good. I can read it also. What are the prognosis for cerebral stroke or spinal MS and bladder function? Okay, so the way that I'm understanding this is, what's the what can somebody expect from their bladder if they have cerebral stroke or these different etiologies? So starting with stroke, usually these patients have detrusor overactivity. So this is a quality of life issue. This is not something that puts them at risk for kidney problems or dialysis. These patients are typically not going to go down that route for dialysis, but rather it becomes a quality of life issue. So they may report incontinence, urinary urgency or frequency. So we have many options for them. These can include medical therapy like beta-3 agonist or anticholinergic medications. Many of these patients also fare well with Botox. Keep in mind that that can predispose them to urinary retention. So you'd want to make sure that that PVR is fairly low to start. But they have very good prognosis. I mean, this is a quality of life issue for them. So typically this can be managed completely with medical therapy or advanced therapy. You asked about MS. MS is so variable, so that can vary from what I've just mentioned for a stroke, for example, to a lesion in the suprasacral region, which would require intermittent catheterization. On the other end of the spectrum, you can have patients that just have a very poorly compliant bladder. Usually these wind up being patients with spina bifida or spinal cord injury that are just refractory to our medical treatments or advanced therapies. And these patients often will, at some point, require either bladder augmentation, which is augmenting a piece of the bowel onto the bladder to improve compliance. And in some cases, even a cystectomy with an ileal conduit, where they would manage with a bag, much like a colostomy, but for urine. So your question is an important one, and the answer I probably could go on for a very long time about. But hopefully that provides you a good basis for how we generally think about it.
Yeah, next question is from the chat only, sir. From the relay layer.
Yes.
You can read out.
Yeah, is there anything we can predict the recovery rate for detrusor inactivity in a patient with a demyelinating disorder? Interesting. So, demyelinating disorder, how do you predict detrusor function in somebody with, for let's say ALS or somebody with MS or something like that? So these different demyelinating disorders can vary based on which disorder it is. Something that's only motor function would be different from something that would, affect the bladder, like multiple sclerosis, for example. And there's not a great way to predict recovery following these insults. And I think that actually that winds up being the case on the neurologic side and on the urologic side. This is a major active area for investigation in a very broad sense. Of course, we're interested urologically in how to predict recovery of function, but people are interested in the musculoskeletal side and the motor side and the neurologic side. I mean, this is in many ways the holy grail for these sorts of disorders. So you bring up an important point, and hopefully in the next years, 5, 10, 15 years, we'll be able to have a good answer for that.
Okay, there are some more members who were to ask.
Yeah, let's see.
Yeah, Shabir Imtaz Ahmed.
Okay, I can read the chat. I didn't catch that. So what's the surveillance for T12?
Hello.
Yes, hello.
Yes, Imtaz.
Hello. I hope
Hi.
I'm audible. First of all,
Yes.
thank you very much, Dr. Glenn, for your wonderful webinar. I learned a lot. So my question is with regards to ongoing research. From your point of view, which of the mentioned research factors is in most urgent need to be explored further?
Yeah, one of the great questions in our field is how can we restore bladder contractility? This is something that's really evaded us so far. We have things that can reduce bladder contractility, anticholinergic agents, beta-3 agonists. How do we promote contractility? Neurogenic bladder, somebody with detrusor dysfunction, underactive bladder. Can we identify a medical agent to improve that? This is a fascinating question in the field. Something that I'm a little bit particularly interested in is how do we prevent urinary tract infections and how do we adequately treat urinary tract infections in this patient population? I mean, these are patients who are often very frequently subject to UTIs, and these are not just simple UTIs. These are UTIs that can, over time, lead to kidney deterioration, pyelonephritis. these sorts of things in these patients who often self-catheterize or have an indwelling catheter. So how can we prevent those sequelae, and how can we adequately prophylax against urinary tract infections? I think those are also open areas for research that I'm actively working on. So maybe I'm a little biased on that side, but those are some major questions open in the field.
Thank you very much, Doctor.
Hey, you're welcome.
I think your research was good, Dr. Glenn. I read about it. So second question from Ahalya.
See here.
Yes, sir. My question is that is there any key red flag symptoms during history taking that suggest urgent neurogenic bladder referral?
Yeah, well, that's a good question. So if somebody is telling you that they have frequent symptoms of autonomic dysreflexia, this would be something that I would categorize as really an urgent matter that would require attention. This probably means, for one thing, that their bladder's not adequately managed. And I'm assuming it's coming from the bladder, right? I mean, you have to make sure that their bowels are optimally managed, that they don't have any other issues below their lesion. But, to me, that would put me over the line to sort of that urgent/emergent scenario. Other things that would warrant, neuro-urologic evaluation on the in the near future would be things like somebody who's got maybe they've had the same catheterization regimen for years, but now they have new onset incontinence or new onset severe urgency between catheterization. So that tells me that their bladder physiology has changed and that they would require probably repeat risk stratification. So we would get imaging, we'd get new urodynamic studies, assessment of their renal function, etc. So those would be some of those factors that would trigger additional evaluation or intervention.
Okay, sir. I have one more question.
Yes.
Can we expect different symptomatology in pediatrics and adult cases related to urogenic bladder disease?
That's a great question. So I deal mostly on the adult side, but we see transitional patients as well, and certainly a lot of the training comes from the pediatric side and a lot of the literature too. So the short end is that, or the short answer rather, is that the physiology is similar, but the patients need to be considered in the context of their age. So we know that catheterization regimens are more likely to be adhered to by somebody in their 30s than somebody in their teens. We know that it's important to really assess, have patients demonstrate that, for example, they are able to catheterize, that they're comfortable doing so. Oftentimes we find that we have a bladder which becomes high risk, not because that's the natural progression of the bladder, but because the patient hasn't been sticking to the regimen that we've been discussing with them. So these are some things that need to be considered in the pediatric population. Depending on the age of the patient, of course, the very young patients or patients who are otherwise unable to do so can't provide you with a history. So you have to go based on your different testing and evaluations. So other considerations to keep in mind. But the surveillance, the treatment regimens are similar across the age ranges for now. That also brings us back to, can we further tailor our management based on different patient factors? And I would include age amongst them. I think this is an important area. People haven't really compared evaluation and management techniques by age and how age can help further refine those to maximize the efficacy. But I think that's a viable area for the future.
Thank you, sir.
You're welcome. Thank you.
Thank you for a great explanation. There is one great question in the chat by Dr. Naveen. So I read it, or you can read. So his question was that once he diagnosed clinically or by symptoms has LMN or UM in bladder, in nutshell, can you please brief us the approach to diagnosis mainly for sacral, infrasacral bladder, how to localize?
So you can look, yeah, thank you for that. So you can look at, for example, the bulbocavernosus reflex. So I mean, this gives you a sense if that reflex is intact, the likelihood that there's an upper motor neuron lesion is high. If it's not intact, the likelihood that there's a lower motor neuron lesion is high. The bulbocavernosus reflex can be elicited by squeezing on the glans penis or the clitoris and evaluating for the anal tone reflex. So if you have an upper motor neuron lesion, this suggests that the sacral spinal cord, the suprasacral spinal cord is involved. If you have a lower motor neuron lesion, this suggests that the sacral spinal cord or infrasacral spinal cord is involved. So the people with the lower motor neuron lesions would be generally speaking at lower risk than the upper motor neuron lesions. I hope that gives you an overall sense of that. I think that there's a lot more nuance to it, but maybe that's for a different forum. But that's generally how we approach it. That's generally how we localize upper versus lower neuron.
There is one more question, Professor. By Dr. Abhay. He's asking, what is your experience with the baclofen for DSD?
Baclofen for DSD. Interesting. This is not something we typically use for DSD. I'm just thinking about your rationale, and I guess that this is I'm wondering whether this is something that you frequently use for DSD, but that typically this is not in our practice. I don't know if any of the other experts can chime in if they do have experience with this, but baclofen, many of our patients are on baclofen, particularly if they have cerebral palsy or other musculoskeletal spasmodic issues, but not commonly for the DSD. Professor Kirschner, any thoughts about that? Do you use that, or have you heard of that?
I get this question quite frequently, but baclofen is far more targeting for striated muscle, and the portion of striated muscle in the external urethral sphincter is low. So it's basically smooth muscle, and baclofen is not targeting smooth muscle. So that's why we sometimes think if patients have difficulties with intermittent catheterization, but it is not a usual. You shouldn't think of baclofen when you treat DSD, that's for sure. We are not targeting the sphincter. We are targeting the bladder, and we want the pressures of the bladder low. And I think there's also another question by Abhav in the chat, cutoff of PDAT for unsafe bladder, which I think is an interesting and good question.
Yeah, I think that's an interesting and good question too. I agree. And as with many of these things, we don't have a set cutoff. The numbers that we arrive at, typically people talk about 40 centimeters of water or 30 centimeters of water. They actually come from the place that I'm at right now, University of Michigan. They come from a study in the 1980s looking at 12 pediatric patients with basically spina bifida. So I think there's a lot to improve in terms of this. I think that probably it's not only the cutoff of PDET, but the amount of time in the filling and emptying cycle during which the PDET is elevated, and how that PDET increases and decreases, and what is the slope of PDET. So usually we think of it as 30 or 40 centimeters of water, but I think that there's probably a lot more to it than that. And I think that this is a viable opportunity for future research.
And I think the clinical experience tends rather to lower values. So, but I agree, it very much has to do with frequency of DO and low compliance and how the overall picture is.
Okay, there is one more question, I think, from Claire. It comes as a follow-up. is there is a thought if you stop the NDO, then the DSD also should settle.
I think the thought is that if you have improved bladder filling function and reduced bladder spasm, whether or not the DSD settles, you're transmitting less pressure to the upper tracts. My understanding is this is the thought process behind it. Some people also try to treat the DSD. People have described Botox in the sphincter. People have described the use of alpha blockers for this. People have looked into sacral neuromodulation, but I think the idea is that at least if you can address the DO, you can improve the overall risk to the upper tracts, but by improving the bladder metrics. Would you agree with that, Professor Kirschner? I'm curious to hear your thoughts.
Yes, yes, I definitely agree. I think we have to get rid of the idea that at least patients with a spinal cord injury, they don't come back to normal voiding. So the voiding aspect is not our main aspect. The main aspect is, as you clearly pointed out, is getting the kidney safe. And until we don't have any medication to increase contractility, it's not the voiding we are concerned about, it's the bladder health and the kidney health. And we address DSD only if it makes problems with the catheterization. And then I would also rather tend to Botox in the sphincter with the risk of incontinence than anything else. And I think there's also an interesting following question.
Yes,
Does
it is
mean more frequent for a higher PDAT, or should it be volume based? More frequent CIC for higher PDAT, or should it be volume based? Yeah, good question. I think that it's a little bit of both, but a little bit of neither. So we look at the compliance of the bladder as well. We want to make sure that most of the bladder's cycle is in a safe state. So it's not only CIC, it's also improving capacity, improving compliance through medical management, through Botox or what have you. So generally speaking, you want to make sure those PDATs are in a reasonable place. If a patient doesn't have any appreciable increase in detrusor pressure until 400 cc's, well, then probably it's safe to only catheterize as frequently as is necessary to not get to 400 cc's. So there's a lot to consider there. But yeah, typically you want to make sure that you're making the regimen consistent with a safe bladder capacity. Is DSD filling or emptying disease? Well, it stands for detrusor sphincter dyssynergia. I think that really it's probably the argument could be made that DSD is both a filling and emptying problem, but let's just be clear that it's not a disease. It's purely a urodynamic phenomenon in the context of a neurologic condition. Yes. Okay.
But I think you should also react to because some patients present high pressure urine DO without leak. Yes, we often see that. And these are the people with most risk. If they leak, the pressure goes down. If they don't leak, the pressure goes up. So that's not a good sign if they don't leak. That's what that's the point. We are focusing on the bladder, not so much on incontinence and on voiding. Is that rightly put? Right.
Yes, agreed. Detrusor leak point pressure less than 60. Yes, a detrusor leak point pressure is basically the lowest pressure at which there's a leak, and actually a lower detrusor leak point pressure is exactly as Professor Kirshner just mentioned, is consistent with a safer bladder. Generally, it's a pop-off valve. And the pop-off valve is not the upper tract in this case. The pop-off valve is out the urethra. So this is in some ways protective. So you don't want a very high detrusor leak point pressure, because then in the context of all of these spasms, that pressure only has one way to go, and that's up towards the upper tract. So yeah, you're less than 60, questionable. The different numbers cited by different literature, typically lower than that, but the lower, the safer typically. Okay. All right. Well, if there's no other questions, and also I actually have a patient who I need to be seeing soon for urodynamics of all things.
Okay.
But I appreciate the opportunity. I appreciate all of you joining us today. Hopefully this has been helpful. And if you're taking the quiz soon, best of luck on it. You'll all be very well prepared if if you paid any bit of attention.
Thank you so much, Professor. So you have a time just for a photo? So we can take
Sure.
a screenshot from
Yeah, we have to have one photo.
Sure.
So
Please.
open your cameras.
And smile.
Okay, so
I think it's always such an, by the looks, you can see that it is a very international crowd. Glenn, and thank you for your contribution.
That's great. It's great to see all the faces. Nice to meet all of you. Hope we bump into each other in the future.
Yes.
yeah, sure. We will. Thank you so much.
So
That's
you
the
make,
smile ones.
okay.
Yeah, sure. Great.
All right.
So yeah, nice crowd, nice people, and very broad spectrum of people.
Thanks very much, everybody. Take care.
Okay, thank you so much, Dr.
Take
Glenn.
care.
Bye-bye.
Thank
Thank you so much, sir.
Bye.
Sure, bye.
Thank you everyone for joining.
Thank you.
You will receive the quiz in few minutes. Thank you. Have a good evening. And Dr. Ruth, when you have to plan, after I sending, I will contact with you. Then we will test. Okay.
Okay, so I leave this meeting and then you contact me, right?
Yes. In 10 minutes, I will contact with you.
Okay. Thank you. See you soon.
Thank you. See you. Yeah.